This video, we're going to talk about some foot pathologies where you might have heel pain, specifically plantar fasciopathy. So we're going to venture into this. And what typically happens here at the Rehab Hub if you're coming to us with some foot pain. Now, we're going to look at different footwear and management plans that we discuss and go through when you come and see us here at the Rehab Hub, possibly with heel pain. So you've maybe got a bit of heel pain, possibly around this area of your heel, at that first footing in the morning when you got up out of bed, or when you've been sitting for a period of time and you go to get up and you get this pain, or maybe it's when you're doing a certain number of miles training, or you walk and you get to a certain point and it just kicks in and it's really sore. It's maybe been going on for a while, you've tried everything that you can, and you're just getting nowhere. So it could be plantar fasciopathy. Things that will happen when you come and see us is that we'll ask you things like, what makes it better? What makes it more painful? And that helps us build a picture of what's going on. When you come in at an appointment, we'll take a full clinical history, but we will also scan this area. So just behind me here, this is a diagnostic ultrasound scanner. I have a postgraduate certificate in diagnostic medical ultrasound. So what would always happen is we would utilise this and we would scan your foot. So we'd actually see what's going on inside the heel. We can see soft tissue with ultrasound, things like fibrous tissue, ligaments, tendons, bursa. We can actually see the plantar fascia. We can, with diagnostic ultrasound, see if there's any inflammation. We use a thing called power Doppler for that. If there was inflammation, we would see plantar fasciitis because there's inflammation there. And if there wasn't any inflammation, it's maybe more of a plantar fasciopathy, so it's more of a chronic condition. And that is important in how we manage it. We're going to talk about that differential diagnosis and how we then treat it. There's multiple ways that this gets treated. First and most important is getting a proper diagnosis, and this is where the ultrasound comes into its own because we can see what it is. Now, when we're looking on ultrasound, we're looking at the cortex of the bone. Has there been any damage to the bone? Is there any breaks? We can see the cortex of the bone. If we did suspect a break, we would send you for x-ray. If we saw changes where the fascia attaches to the calcaneal tuberosity and if there was inflammation, more of an enthesitis, that can link into a bigger clinical picture where we might need to send you for further referrals and possibly on to things like rheumatology. So we can pick up various different conditions by looking and seeing, but depends what we're seeing. Sometimes we can see tears in the tissue, sometimes we can see thickening of the tissue, sometimes we can see fibromas in the tissue. That then helps us build a picture of what we do with you. How do we best help you? Now, say that we just see something that's really common, which is thickening and degeneration of the tissue. So that would be much more of a plantar fasciopathy. So how do we treat that here at the Rehab Hub? Figuring out why it's there in the first place. Why has this happened? For that clinical picture that you give us when you come in, get a full history. Has it been an injury or has this been chronic? Is there underlying health conditions? Because there could be something going on systemically in your body that's causing this. So we start to explore that and make sure all of those boxes are ticked and we're happy with the diagnosis we've got and the plan that we're then going to build. Now, if we thought it's more chronic, did a big walk, irritated it, and this is where we're at, and you go off the hamster wheel of pain, then how we would manage that would be, one, changing the load that's going through the tissue. So we might have to offload this and then build it up. So that might mean we use something called an orthotic. As podiatrists, we get a bit of a bad rep in saying all we do is prescribe orthotics. I am not saying some don't do that. It's certainly not what we do in here, but the orthotics have their place to help a patient in that management plan. It's not the only thing in it. So we'll sometimes maybe do something like this, where we might use an orthotic to support the foot while it is being rehabbed. It wouldn't be a standalone thing unless there's a particular reason for that. We would be rehabbing this, but that tissue adaptability and change usually takes about 12 weeks for the tissue to really start to see a big difference. So, for example, I want to go out and be able to walk and not be in pain. This is where something like this can come in and talk about and explore how we build a management plan. First and foremost, we've got our diagnosis, chronic plantar fasciopathy. Go on, say it's 9 months, and you're just not getting out of the bed. So the first thing we're going to do is rehab this. So we get patient education. We're going to teach them about strengthening the intrinsic muscles, trying to build up that strength in the tissue. If possible, you need to lose weight, give you a little bit of support for that as well, because sometimes the load going through, if we can reduce the load, brilliant. So rehab will always be part, getting the foot strong and stable, but also considering stuff proximal to the foot as well, because there might be things happening up at the knee and the hip that may be contributing to this load as well. Making sure we're looking at that overall picture and building a rehab program that's specific not only to the foot, but it's connecting to the rest of your body as well. So that's the first thing there, rehab. So sometimes your footwear does play a massive part, and it's about the right footwear for the right person at the right time. So if your foot is needing supported and you're getting pain and you're trying to build up that strength, then certainly for a short period of time, you want a more structured shoe. I'm going to show you this shoe, which is much more of a minimalist shoe. Right now, I love minimalist shoes. Lovely white toe box here, pretty flat. It's not got much to it. This shoe is okay in the right person, but for somebody that's coming into us that has got a plantar fasciopathy, this would, in the short term, absolutely kill them. In the long term, we might be able to get them into something like this with a good bit of work in rehab. But initially, we would be saying to them, if it bends like this, it's not going to be any use because it's not offering any support. And if you can wring it out like a dishcloth, which you can see with this. So this is a minimalist shoe. Now, we don't hate minimalist shoes as podiatrists, but again, it's the right shoe for the right person at the right time. So for this, we could build somebody up to wearing a shoe like this. But if they're in pain and we want to get out walking and do the things we love, then we support them in doing that by going into something more like this. Now, this is a HOKA Bondi A. What we love about this rocker doesn't bend, so it's supporting that foot. For some feet, especially if they've got arthritis in the foot, they're going to need to go into something like this. It just depends, because sometimes, even with all the rehab in the world, I am not going to improve your arthritis. I'm not going to fix it. Nobody's going to fix that in Egypt. And everybody's circumstances are different. For some people, might manage with the rehab and going into a more minimalist shoe if they've got joint arthritis. But for somebody else, that might aggravate their pain and make their symptoms worse. So there isn't a if this, then this. It isn't always the case. But for somebody that is in pain, then having a shoe structured like this is excellent for them. This is the orthopedic range. The features that we love about this, it doesn't bend. And see how this lifts up, so it's almost like a rocker bottom. That helps with ambulation. It helps with that toe off and that rocker part. What happens when you're walking, the windlass mechanism, when you're walking, your big toe bends. And as your big toe bends, the arch lifts. As the arch lifts, the tibia rotates, and then the femur rotates, and it all links right up. When you've got a pathology or a dysfunction, something's happening, and we would assess that all part of your assessment, how that's all functioning. But if that's not all working and we need to rehab it, it takes time. This is where the shoe facilitates the windlass mechanism, but not only helps reduce some of the pain here, but it can help with assisting in compensatory mechanisms that you might be doing as a result of what's happening down here that may be causing you some issues, for example, knee pain, hip pain, back pain. These can be an absolute godsend, not always forever, but as we are rehabbing, as it takes time, we need to do something in that interim. Doesn't bend, and it's got that rocker bottom, and it doesn't twist. It's got calcaneal support, so it's supporting the motion and the movement at the back of your heel. It's got a medial arch support. It's got this arch support in the inside part of your foot. I'll show you what that looks like in an insole, because a lot of the time, prescriptions inside this shoe are very similar to what we would give for a plantar fasciopathy orthotic insole. There's a deep shoe. Heel's not going to be sliding out of it. It's not too shallow. So these are all features we love as podiatrists, especially when you get a foot pathology. I would wear minimalist shoes, but it's the right shoe for the right person at the right time, as long as you're strong enough and your feet are pliable enough to deal with them. We don't hate them. Sometimes we get a bit of a bad reputation. I'm going to talk about summer shoes as well. This is a kind of flip-flop, and I quite like this. You get different ones called arches as well. So when you've got foot problems, wearing a really flat flip-flop is going to be agony, right? It's going to kill you. So these kind of ones where they've got that arch support, can you see that? And it's got a little bit of a deep heel cup. You want to have something that's got a wee bit of structure. Some of you will like this or not. I don't really have any opinion on that. Whatever works for you, as long as it's not rubbing and causing you any blisters or any sores. Essentially, this support here in that inside arch, that's what you want. Okay, so when you get into a shop, you're like, does it bend? Don't buy it. Does it twist? I'm not going to buy it. It's got a bit of medial arch support and it's got a deep heel cup. That's your main sides for people that have got foot pain, not for everybody. If your feet are fine, you can wear what you like. Now, an insole. These are display model that actually Lulu made for us. These are bespokely made. In here, we use orthotic therapy for various different things, and it might be something that we use. We might only use these for about 12 weeks on a patient. These generally cost anywhere between £140 to £180. They're custom made and 3D printed. We take a 3D image of your foot. That goes to the software. We then build an orthotic around your foot and a prescription based on your pathology. This is then 3D printed and we put a top cover on them. We can do these in any colour. Pair here, this is what it looks like without the top cover on, which is absolutely fine as well. You don't necessarily need that top cover. This particular prescription here has got a medial arch support, it's got a deep heel cup, and it's only 3/4 leads because we only need the prescription at that level. We only need to control what's happening around the heel and into the arch. There's no point in having all that bulk in a shoe if there's no prescription at the front. Some people like a full length because they say it just feels weird. They don't like that sensation in their foot. There just would be no prescription at the end of that. Orthotics have their place in this. I'm not saying that every client that comes into us gets a pair of insoles for their plantar fasciopathy. It depends on what that client's saying to us. They might say to me that they want to go out walking, they want to go play their round of golf, they don't want to have, they've not got time to wait on the rehab working. That's when I would use that. I would be like, we're going to use this and we'll start to wean you off it over the next 3 months. We'll start to take you off it as your strength is improving. But also we've got some patients that, let's face it, they're not going to do their rehab. Their personality is, they're just not going to do it. So what do we do with them? That is where things like orthotics can play their part, because they are of a personality or there are circumstances where they just won't do it. So it's not ideal, but that happens. The foot gets weaker over time. We don't want that, but we still want that person as much as we can to be able to ambulate and be pain-free. Every patient is different and how we manage them is different. Another treatment we can offer would be a steroid injection. If it was really and it did have inflammation in it, then I would possibly do a steroid injection into that area. Certainly not a first line thing to do, but if it was particularly bad, we would usually do a steroid injection just to this point here. Again, that's something that it depends on the patient, it depends on the circumstances, but that's something that we can do. Another thing that we would sometimes build into this, usually before a steroid injection, would be shockwave therapy. Shockwave therapy causes damage to the tissue to stimulate healing and new production of tissue. That coupled with rehabilitation, possibly orthotic therapy, all part of a plan to help get you out of pain. So it's not one size fits all, it's not just one thing, it's this overall plan. So that is a little bit about managing heel pain that is showing to be plantar fasciopathy, no active inflammation.